I'm very excited to introduce the last session, which is on technology integration. And our first speaker is going to be Dr. Kenneth Johnson. He's the Director of Outpatient Rehabilitation Services at Johns Hopkins Hospital. And he's also the Director for the new Center for Rehab Technology, the CERT, which we have sort of created as we started to execute on the Sheikh Khalifa Stroke Institute model of care. Because we realize that there is so much rehabilitation technology out there, but are we integrating it? And it's not just about the technology, it's about the people who would use the technology, and it's the people who provide the care to the patients. So it's really with the partnership. There is a very good system already within the hospital. We have a very robust team structure for acute care services and for inpatient rehabilitation services. But outpatient is generally a bit, it's so large that it's difficult to link it with the inpatient, and it was only possible with the partnership of Ken Johnson. So without further ado, welcome Ken, and really looking forward to your talk.
Thank you so much, Preeti. It is a great honor to be here today, and I want to thank all of you for joining in and participating today as we talk about our work and activities with the Sheikh Khalifa Stroke Institute. So again, thank you. It's a great honor to be a part of this esteemed panel of presenters. I have no relevant disclosures to report that present a conflict of interest for this talk. My discussion objectives today are to talk about the process that we went through to build the team. We'll talk about some of the concepts and some of the tools that we used in our decision-making and assembly, how those drove some of our operational workflows and communication and other activities that spawned from the Stroke Institute. And I'll share a little bit of historical perspective on how investments in time, how we see trends and changes in our work and volume. So as many of you know, Hopkins is founded on several key tenets, that of excellence in patient care, research, training, and public policy. All of those are aimed at improving the quality of life of the patients and population that we serve. As we were presented with how to implement a very complicated process of moving patients through a set and prescribed workflow, we had, as the team has talked about and will continue to talk about, the evaluation process, the details that went into the decision making, and thankfully that was not on me. But getting patients to flow through this stratified level of care, looking at high intensity, moderate, low intensity, and then into tele-rehab in the community, we had to set up a pretty high-powered team in order to pull this off. And I'm very grateful to be a part of that. So sort of looking back into the past, how to go about such a daunting task, I focused on three tenets that I believe have been a hallmark of our success at Hopkins. And that is first focusing on the talent that we have on our team, the technology that we employ, and the training methods that go into developing that process. And, coming in and looking at, now not just the outpatient process, but now the entire process, we were confronted with this challenge of, referrals coming in from all different angles. We've got patients that are flowing into multiple different pathways, and trying to then break it down to figure out, who are the right people to be at the table, or in many cases on the computer on Zoom, thanks to the pandemic. The challenge really was, like any complex problem we see in the clinic, when we break it down into its constituent components, something that seems nearly impossible becomes manageable. I had the great pleasure of working with Dr. Raghavan closely for many months as we were talking through this. And you'll understand when I say talking through this, you'll get to learn a little bit, maybe too much about me, but you'll see how we tried to make the complex manageable. So, but part of this challenge that we faced was, a shift in our populations. It was a shift in focus. My background is more on the orthopedic and musculoskeletal side. So I had the great privilege of learning how to think more like a neurorehabilitation operations manager. And what we saw happening at the hospital, and some of this was, in relation to COVID as well, was our visit volume. So in 2018, so in FY18, when the concept of the Stroke Institute was being discussed and planned, you could see that neurorehabilitation was a very small part of what we did at the hospital. The largest bulk of the business, 75% of it was musculoskeletal in nature. As we began to move with intention, those patient populations began to shift. And so you can see within a span of a relatively short time, we had an almost reversal in our patient populations at the hospital. So a 200% increase in our neuro population, again, was another one of those challenges that we had to face. So this timeline here kind of shows, we started these discussions in and around, fiscal year 19, and that was Dr. Raghavan and myself largely talking conceptually for quite a period of time. We had a budget to work off of and things like that, but figuring out who the right people and their roles and responsibilities, and that was a challenge. As we began to put the pieces together in FY20, we started to expand that sphere. We named our outpatient program manager, Dr. Pei-Ting Lien. We had project specialists that came in late in 2019, and their role became very evident, as you'll learn from Dr. Haley Cook after my talk. Shortly after the pandemic was really when we began the massive deployment and rollout. How do we shift from all this inpatient care to working remotely and coming up with new strategies to help our patients progress? And then we added our navigator position, and that's where Dr. Latay Jenkins came in. Latay did a phenomenal job of taking that incredible mess and process that you saw a few slides ago and helping it to connect the dots and connect the patients with the providers and the locations and the templates. And without that effort, we could have never succeeded. And then in FY21, we had a really robust recruitment and hiring process, looking both internally and externally for many months, an arduous and exhaustive review process for the clinical specialist team that we've put together with Dr. Spencer Gonzaga, Brittany Colbank, our OT, Dr. Gina Kim, our OT, and Aaron Jedlanek. So from there, in FY22, this year's been an interesting year as we've begun to build out the Johns Hopkins Center for Emerging Rehab Technology. And you'll learn a lot more about that shortly, but for there, we've seen the migration of the role of a project specialist into a more senior role on that, and the expansion of our technology review team. As we look into FY23, you just learned about the importance of care coordination, and we found that the role of the navigator is quite a challenging one, and it needs more support. So expanding those support and services side are a big part of where we're heading in FY23. As we look beyond, I think there's only opportunity and excitement, looking at outreach and how do we begin to operationalize and mobilize this, not just in other facilities, as we've just recently opened our first freestanding outpatient facility that is targeted for the neurorehabilitation population, but then also taking it abroad. And we're excited about some emerging opportunities that may be on the African continent as well. So, in putting this together, we look to the West Point leadership model as something that has always resonated well with me, and that is, first, know yourself. If you don't know who you are, it's hard to figure out, how to lead yourself, and more importantly, how to lead others. So we balance that with our, core beliefs and values, our commitments to our ethics, to quality standards, to our outcomes, expectations, care considerations, and what drives us. So within that mindset, we began to look more deeply into how do we better understand ourselves as individuals, but then how do we understand our team as we begin to form them. So the mission of Hopkins, having all of these sort of metrics and precision-based thinking and thought process, pushed us to look in means of objective measure. And so to do that, we used a tool called emergenetics. Emergenetics is really a pattern of thinking and behaving that emerged from our genetic blueprint and life experiences. It is an assessment tool that looks not at personality, but we've done MBTI and other types of personality inventories in the past, but we wanted to better understand how we think, how we function, and how we work. And so I think sometimes one of the toughest things is looking at yourself. And so, as you'll see, the breakdown in emergenetics is in 4 different domains. And there's some other subcategories that we don't have the time to go into today, but, those being analytical, conceptual, social, and structural. And the idea is not to look at where we are weak, but to play to our strengths. I talked earlier about, the months of getting to know Dr. Raghavan and talking through her vision and understanding what her goals and that of the executive directors of the Stroke Institute. And so getting to know and understand how they function and how they thought was critical. So, for me, being very conceptual and social, I like to talk, which I'm stressed I'm going to go over on my time limit here, so I'm watching the clock. You can see that doesn't leave a whole lot of room for something else, and that's creating structure. And so I had to look, internally for people that could play to that strength as it fit into their domain. So I wanted to share, this is an amalgam of our Stroke Institute leadership, and you can see my profile there on the left, and how when we look at the team members, the high distribution of structure is a great strength of that team. And so when we combine them together by valuing where we are all strong, it presented us with a very unique, almost perfect balance of that structural, analytical, conceptual, and social aspect. And so, for me, it's been very rewarding to learn from them and to appreciate them, ask questions more, and tried to understand how sometimes my forward-thinking brain doesn't always think through all the important steps that are critical to building a successful foundation for us to build on. And their work in really helping to bring about the reality of this vision is something that it will always be one of my, stronger achievements. So to do that, it started first with people. As Liz Wiseman said in her book, Multipliers, that talent is magnetic. As we began to grow in our service line, outpatient rehabilitation, very early on, we identified the importance of having, our board certified specialists. Accomplished people attract other accomplished people. Fellowship trained people attract other fellowship trained people. So our ability to pull in talent, which at times is quite a challenge in the competitive market that we're in today. The Great Resignation has caused a lot of angst amongst a lot of administrators and program managers around the country. Knock on wood, we've been very blessed with predominantly very stable workforce and a very stable team as we've been growing. So as a leader, we learn from our mistakes. And, one of those mistakes that I've made in the past was simply hiring based off of a skill. It's a great temptation to do that because I need this skill set. I need. But the reality is culture and chemistry and that ability to feel comfortable with the people that are around is critical for building on trust, which, within the book 5 Dysfunctions of a Team, the foundational element of any team is that of trust. And so I'm very grateful to say to you today, I have a high degree of trust in my team. So, as we look at how this has evolved, it's pushed us into now we've got these really good people that are coming on board and filling different roles. And, there's the leadership side, but then we also have to have development for the future. And that's where this idea of training to retain is coming into play. And we've seen the success in other areas. We have orthopedic, sports, we have neuro PT residencies. And in each one of these areas where we've established an education, post-professional education program, we've seen it recruit and attract people from all over the country. And so, as we look to the future, we're really excited about some of the programs that are currently being developed right now. One is an occupational therapy fellowship for our occupational therapy colleagues, and then also an outpatient rehabilitation fellowship, both in the OT and PT side. And then this year, we were also really excited to add complement to our existing outpatient neuro speech pathology fellowship to then add one also for that in voice. So there's a lot of great things that are going on, and sort of, as iron sharpens iron, we keep challenging and pushing one another to find new ways to pull talent in. We look to a lot of the different continuing professional development areas, because as we're bringing people in, it's getting the team on board. So whether it's the grand rounds meetings, the weekly stroke team in servicing and communications, having specialists come from around the world to teach and train our staff, from looking at some of our strength and conditioning colleagues and pulling in some very fundamental neuroreflexive strength pattern training. And then also using asynchronous education tools such as MedBridge. We've pulled from resources from a number of different directions, in order to help support, bolster, encourage, and retain our staff. And then the last piece is really this one of technology, and I won't talk a whole lot about the mechanics of the technology piece because that'll be covered by my colleague, Dr. Cook. But technology integration into practice is one of the biggest challenges, both as a provider, but also as a director and administrator. We invest large sums of money into these different tools, and you hope you're buying the right tool. How do you know you're getting the right tool for what you need? And it really is just the tip of the iceberg. It's very easy. For some easier than others, but it's relatively easy to get equipment in. Getting it to integrate is a whole nother story. The training, the education, the effort that goes into that, and then the conceptual buy-in, because sometimes technology may not fit the philosophical directive of a therapist, and that's a tough conversation. It's a tough thing to deal with as well. But at the end of the day, our patients are looking to us for solutions. They're looking for the latest and the greatest. They're faced with what's for them, it's their life's most greatest obstacle. And so I see it as our job to constantly be on the lookout for any tool or technology or technique that could help them to achieve their goals. So, real quick, to provide some historical perspective on our volumes, I started here back in 2010, and our volumes were relatively small in terms of annual patient flow. We saw that grow substantially, and as many would expect, the pandemic took its toll on the back end of FY20 and on the front end of FY21. And as we look to close out FY22, we're hopeful that we're seeing that trend line begin to soar upwards. And with the goal of clinic expansion, aggressive clinic expansion over the next 3 to 5 years, we are really excited about where this direction is going to take us. But how do we get there? We've talked about the talent. We've talked about some of the training, retaining. How do we grow our talent pool organically? But then equipping them, it goes hand in hand. There was strategic investments that were made, and for me, I still remember the first capital piece of equipment I bought at Hopkins was a Pilates reformer for a performing arts therapist that was very passionate about developing that population. And, we can talk about how that has flourished into another one of our signature outpatient rehabilitation programs at Hopkins, but it started with an $8,500 investment. And, as we did well with what we were given, we demonstrated stewardship, we steadily were given more and more. And so, we saw a decline in that spending as related to the pandemic. Our focus shifted. But even in the midst of the pandemic, and I give great credit to our leadership at the institution, while we were saddled with a challenge that had never been seen before, there still was ongoing investment. And all of that $270,000 investment in FY20 and was targeting tools and technologies to help us better manage our neurological population, and specifically our stroke population, as they were trying to cope with needing to rehab at home. And Haley will talk about that a little bit more in a minute. So, as we've kind of bottomed out, like we said, we're here in FY22. We've just opened a new clinics. We've invested heavy in our first, neuro-specific clinic. And, as we say, technology accelerates. And this is coming from the book Good to Great by Jim Collins. And, you know, using tools that can be both synchronous and asynchronous have been really invaluable in engaging our staff. You know, we had projects and things to work through, and out of that, our Johns Hopkins cert was created. Now, I'm going to use a little bit of this slide's a little bit out of context, because here we are talking about, you know, investments in our neurorehabilitation. And, you know, part of the challenge with having any types of longitudinal measures is having consistent measurement tools. And for many years, we used the Gallup Q12 as a measurement tool for our employee engagement. And then we shifted away from that and began using a different tool that's a health system-wide tool. But what I learned from that experience in monitoring for those first few years, and you saw that in those trend lines, you know, we saw improvement and investment in technology that had positive benefit. When I took over in 2010, the turnover rate at the clinic I was at was well over 20%. You know, now our annual turnovers are less than 5% per year. And, you know, pleased to report that the majority of those are oftentimes when someone is moving out of the area with the spouse or other activity. But I knew that and was able to see that investing, you know, in the culture, you know, so where we have a friend at work, someone that, you know, you identify with, you care about, communicate with, and trust, is still in my mind, you know, that's the social part of me that you saw earlier, is that relationships are very important. But when we develop people, we train them, and when we equip them with tools and technologies, we see improvements across the board. So some of the books that I've mentioned, you know, these have been very central to me in my development and have helped me in the concepts that have brought us here today to talk. And I'd just like to wrap and close. You know, there's, you know, importance of all of this is employee engagement. You know, again, you can buy the best tool, but if you don't have somebody to use it, it's going to sit in a corner. I can fill a position with a warm body, but if it's not a body that wants to be there and wants to get along with other people and really cares about patients, we're just paying another salary. So if I wanted to say that I invest in people's education, we would just give them an education benefit and let them spend it however they want to. We've got a great team of people. This year we formed our outpatient education council, and we have a multidisciplinary, multi-specialty group of people involved in the education decision process and the courses and trainings that we bring in. We try to make them as meaningful and strategic as possible. So with that, I hope it kind of makes a little bit of sense. You know, I'm just intensely grateful for the support of Dr. Raghavan and the encouragement throughout this time, and her sharing her knowledge with me, but, you know, that of our leaders, Dr. Justin MacArthur and Dr. Pablo Selnick at the helm of the Stroke Institute, and to all of the many people that have supported me, Dr. Jenkins, Dr. Cook, Dr. Lien, and our wonderful clinical specialist team. So thank you.